Hi, I'm Gurpreet Dhaliwal. I'm the site director for the internal medicine clerkship at the San Francisco VA.
And I'm Ed Kim, and I'm the clerkship director for surgery at the VA San Francisco Medical Center.
This presentation that we're doing here builds on our previous presentation where we tried to draw a distinction between medicine, where a lot of the reasoning focuses on diagnosis, and surgery, where a lot of the reasoning focuses on treatment. And we're going to build on the latter in this presentation.
So, what is treatment-based or treatment-focused clinical reasoning, and why is it relevant? And basically, it's fairly simple. It's trying to figure out what the best treatment is for your patient. So, what the clinical reasoning behind that is, and it's really important both for medical and surgical discipline because it's not just about operations or procedures, but it's also about putting people on medications. It's typically talked more or more involved oftentimes in surgical and procedural specialties because treatment options that have significant potential to do harm are the ones that often require more thought.
And I want to emphasize that point that even though medicine sort of has the reputation as being focused on diagnosis, we actually do a lot of therapeutic reasoning as well. The risks and benefits of chemotherapy or antibiotics or cardiovascular medication. So the principles here are to optimize your performance in surgery, but they definitely apply to medicine as well.
So here's a typical example or a context. So on the surgical rotation or on the surgical service, often we're consulted by the emergency room or inpatient, consult service. And let's say there's a patient down in the ED with acute appendicitis. The initial evaluation has been initiated, and they usually have labs and CT scan by the time we're called. And what we're trying to describe what goes through the mind of a surgeon as we go down to see this patient, or as we see the patient and decide what might be the best option for him.
And to give you a sense, remember that this patient has been on a journey that precedes a surgical consult. So the previous presentation we did shows that there's a spectrum, and early on, there was a lot of diagnostic reasoning. But as the diagnosis becomes clear that this patient has acute appendicitis, then there's a shift that's happening to therapeutic options, and that's getting into the mind of the surgeon as they approach this patient.
So the first thing that we do is we try to go and confirm the diagnosis. We don't start out with a broad differential. We actually start out with a focused mindset, and we basically compare how the patient's presenting with what the classic presentation or what the classic textbook presentation is.
So in this case, it'd be sort of a knowledge of the classic presentation of appendicitis, what the student would need.
Exactly. And we do see the patients, on our own. We talk to the patient, get a good history, and also do an exam, as well as reviewing all the clinical information such as the labs and the radiographic studies.
And I see that you're emphasizing there that's hypothesis-driven, and I think to some degree reflects a little bit of a difference. At medicine, we oftentimes try to start with a blank slate, even if we're told the complaint or even a final diagnosis, and say, let us start from scratch. And I think what I'm hearing you say is a little more of a trust but verify.
Exactly, yes.
Sort of trusting what the imaging or my ED or medicine colleagues told me, but your job is to verify it.
Right. And I think you can attest to the fact that most people present, nobody really presents with the classic presentation. There's always often some discrepancies because of the individual variations in anatomy, physiology, and whatnot. So it's really important to note all the inconsistencies as well as the factors that support the diagnosis, and then with the inconsistencies, figure out why they're there or whether they're significant enough to raise the possibility that the diagnosis might not be correct and may require additional studies or other thoughts.
So, can I just do an example? Like, if you guys send a student down to work up a patient with appendicitis, they do their reading and remind themselves that there's periumbilical pain, that it radiates to the right lower quadrant, that there's anorexia. If they find there's a mismatch, like the patient doesn't have anorexia, they say, hey, doc, I'm actually pretty hungry. Then part of their job is to figure out, is that mismatch big enough of a deal that I should think about something other than appendicitis?
Absolutely, yeah.
But also, could they say, well, maybe it's okay not to have a perfect textbook presentation?
Exactly. I think it helps them to understand the variation.
Yeah.
See the pattern, what's definitely important part of the pattern, and what may be not as important. And another way to look at it is like sensitivity and specificity of certain specific clinical
findings,
presentation.
etc. Yeah, I bet. I mean, another way to think about it is right. Like, variation of disease is part of why you do these clerkships, to see hopefully multiple versions of appendicitis. And through those exposures, you learn that some things aren't in every case, but some things are non-negotiable, like the pain eventually being in the right lower quadrant or otherwise. But I like your point you made about avoiding confirmation bias. It is possible that the student would be sent down to see acute appendicitis, and even though there's 1, 2, 3, 4 non-compatible features, they stay focused on that and might miss that actually it is a time to step back and realize this person has a kidney stone or something else.
Right, absolutely. So the next step after that is, it sounds pretty simple, but it's actually very important, which is to clarify why we're treating the patient. What's the reason for treatment? What is the benefit of the treatment? And some of the benefit can be very compelling. And for example, in the case of our acute appendicitis, it's an acute infection. It can cause sepsis. People can die from it. So it's clearly a threat to life in the short term, and it's urgent. But there are other conditions that people get treated for both medically and surgically that are more quality of life. They're more chronic. It's more electives. Things like hernias and hemorrhoids are a couple of good examples from a surgical standpoint. And then even less compelling, or I wouldn't say compelling, but even less like urgent, are things like preventive medicine, things where the patient is doing okay. They're fine the way they are right now. It's just trying to get them better in the future. So
yeah, and what I see here, it seems like there's another layer of knowledge that the student has to start to integrate, which is not just that, like in this acute appendicitis case, they should tell their attending a resident, like, I think they should have an operation, but they should justify what's the reason for an operation. So in the appendicitis case, you say, I think he needs it today because there's otherwise a risk of perforation and abscess and perhaps sepsis. Would you expect them to say that in their presentation?
Yeah, I think so. A strength of indication is very important, and I would say that it's probably even more important, actually, in like the quality of life issues. Where there is a little bit of wiggle room in terms of what can be done. Yeah. But even in the threat to life conditions, there are options and whatnot. So
yeah. No, I think that would be a note to just make sure you elaborate to your attending a resident, not just what it is, but why we're doing that.
Exactly. And next, we basically list what the treatment options are, and basically describe and define the risk part of the risk and benefit. So we basically try to list what the options are, both from the least invasive to the most invasive. We also need to talk not just what they are, but what the rates of success are, how successful the treatment options are, what their complications are, how often they occur, and to also talk about the common complications, as well as the most devastating complications.
Can I ask you in that first thing, like if a student was trying to present the options for the acute appendicitis case, would you expect them to know, for instance, that it could be an appendectomy, open or laparoscopic, and that you could do antibiotic management? Is that the sort of menu you'd want to hear from
absolutely.
them?
Yeah.
Okay.
I think especially with more recent studies and thought, I think the option of IV antibiotics is something that should be discussed.
Okay,
and I think
so students should know that.
Right. I think it would, make for a much more fruitful discussion.
And then I think you're asking about in this therapeutic reasoning about knowing the complications of the treatments. Are you expecting them to know the numbers, like that? There's a 5% rate of perforation, or are you expecting them to have a ballpark?
Yeah, I'm glad you asked, because this is actually a very difficult thing to do, and there's definitely grades of sophistication with it.
Yeah.
And I think it would be too much to ask, honestly, for a third-year, clerk medical student to actually know the specific numbers. That would be a lot.
Okay.
I think just kind of more of a qualitative, a lot, a little, frequent, occasional, rare, it would be helpful. The numbers, which usually are derived from the studies and whatnot, we more expect from our interns or residents, or even more our senior.
Ready.
Exactly.
And I would say, honestly, that reflects, it may feel a little unscientific to use adjectives instead of numbers, but I think oftentimes if you even look at our therapeutic reasoning on medicine, we oftentimes will speak in the same way, say, well, I'm going to give this antibiotic, the side effects are interstitial nephritis. That doesn't happen that often. A good number of patients do get a drug rash, but there's the rare complication of Stevens-Johnson. And I think when people narrate that way, we find that very acceptable in medicine. We don't hold their feet to the fire and say, but what are the percentages for each one of them?
Exactly.
And so I think that's fair to ask students to at least have a sense of how common or rare it is.
Exactly.
I mean, maybe there's a time later to know the exact numbers.
Definitely. And then the final step is to make the choice for the individual patient. You got to weigh the risks and benefit, find the right balance in terms of treatment, the right balance of risk and right balance of the benefit.
For instance, their proposal. So you're saying if they made the proposal that this patient should go to the operating room for an appendectomy, you would want to hear a risk benefit analysis after they say that sentence, for instance.
Yeah, absolutely. I think too many students just say, "Oh, this patient has acute appendicitis because of this and this," and then the treatment plan is to go to the operating room.
Mm-hmm.
And there's no talk of what the risks and benefits are and what the options are.
Yeah.
For example, if an 80-year-old patient with CHF comes in with acute appendicitis, the antibiotics might be the best option, and you can argue for it based on the risk-benefit for that patient.
Yeah, I like that notion. I think it reflects what we think about in medicine too. Like, it's not enough to give the right answer. Like, maybe in the healthier patient, the right answer is to go to the OR. But it's like teachers who say, "Listen, I don't just want your answer. I want you to show your work." Like, remember your math teacher, or your physics teacher would not give you credit just for the right answer. Show your work. And it seems like in the clerkship, when it's therapeutic reasoning, it's not just picking the therapy, but saying, "And I've analyzed the benefits of this surgery and the risks of it."
I'll even I'll say, like, yeah, I'm even jealous sometimes to see students on medicine give this great differential diagnosis and their reasoning.
Yeah.
And then on surgery, we have this blank.
Yeah.
As if there is no reasoning.
No, but our whole point of this presentation is so there's a lot of reasoning.
Exactly.
And to be fair, sometimes the teachers don't always articulate it, but if the student does it, they'll get the feedback from the teacher.
Right, exactly. They get the credit for the thinking.
No, I think it's a really good model of how you go through it. It sounds like there must be a little more complexity than just listing risks and benefits, and I'm wondering how much more sophistication needs to go into it for a student presentation, per se.
Yeah, so I think that's a good point. It is, the idea of risks and benefits and informed consent is very, very complicated. It's a lot more complicated than I think what an initial, novice may look at. Because a lot of this is making decisions in the face of uncertainty, and our understanding of success and complication, what their rates are often from empirical data. What happens? What did we observe? Both in prospective as well as retrospective studies. And these numbers are estimates and averages. So patients have to make decisions, or we have to make decisions based on averages and what the odds are. Yeah. And there are modifiable factors based on the patient, as well as the comorbidities, as well as the individual, specific disease itself. And so, the art of, as I think we're talking about, is where does your patient lie on this kind of bell curve of risks and benefits, or estimates of what the likelihood that they will have a successful outcome or a poor outcome.
Yeah, and I think if I was to be honest, I'd say, like, as a non-surgeon, or if I was a student on the rotation, I think the thing I might look up in an article or up to date as a percent complication risk is sort of the starting point. That's the science. But then the art, as you alluded to, is based on this patient and our hospital and the medicines on board. How does that change that number that I looked up? And that's the art of surgery, which I think is why you do this rotation, to learn from the residents and attendings who have done that before. I think that's a great enhancement to your learning by doing this.
Yeah, and I think our next presentation is going to go into more depth about this, the kind of the nuanced part of making the decisions and uncertainty, as well as the informed consent.
Terrific.
Great. Thank you for listening.
Thank you so much.